So good afternoon, ladies and gentlemen. I'm really pleased to be here today. My name is Eva Compérat. I am a pathologist, uropathologist. I'm doing uropathology for more than 20 years now, so I have small experience, let's say like this. And I have been working in France for 28 years, and now I'm back in Austria, my country of origin, where I'm at the Medical University of Vienna, which is the biggest faculty in Austria. So the Gleason score is something which was found by Donald Gleason in the 60s, so it's very, very old really. And he invented a 5-scale score for the differentiation of prostate cancer. So 1 for him was really very well differentiated, not very aggressive, and 5 was extremely poorly differentiated and aggressive tumors. But Gleason 1 doesn't exist because he didn't have any immunohistochemistry, and we found in the 80s, we found immunohistochemistry which helped us to sort things out. So now we know that Gleason 1, what he described, was a benign lesion, and then we started with Gleason 2. And Gleason 2 was more or less abolished on prostate biopsies, and you always have to be very careful between the biopsies and the prostatectomies, because very often things are not exactly the same. Although we have more or less really tried to be as homogeneous now as we can. But Gleason 2 was abolished in about 2009 because we said we're not sure on the biopsies whether this is not a well-differentiated, higher or less good differentiated gland. So we said, well, no Gleason 2 on biopsies. So when we do prostate biopsy, we start always with Gleason 3. And the Gleason score is that you have always 2 aspects. So if everything looks the same, you have a Gleason score on the biopsy. We're still talking about biopsies, 3 plus 3. So this is really the lowest, which means it's a Gleason 6, which looks extremely high, but this is really the lowest. So, and then we always have to say which is the most frequent and which is the most aggressive. So if we have, let's say, Gleason 3, 60%, and Gleason 4, 40% on a biopsy, we say it's a Gleason 7, 3 plus 4. If we have, let's say, Gleason 4, 60%, and Gleason 3, 40%, it is still a Gleason 7, but it's a Gleason 7, 4 plus 3, which is a completely different history. And this is the reason why in 2016 the WHO decided to make these grade groups. And we have 5 grade groups now. The first grade group is grade group 1, where the Gleason 6 is the equivalent. So when we talk about ISUP 1 or grade group 1, it's really Gleason 6. It's the lowest you can have. It's the best differentiated. It's not very aggressive. Very often these patients are in active surveillance. If you have, let's say, grade group 3, we know it's a Gleason 4 plus 3. If you have grade group 4, it's 4 plus 4 or 3 plus 5, which is pretty rare. And if you have Gleason grade group 5, well, then you have either 4 plus 5 or 5 plus 4 or 5 plus 5, which is poorly differentiated. So this is really a little bit to explain the Gleason. So don't be astonished if you see 6 in a report, because it's grade group 1. And anyway, we give in the conclusion the grade groups too. So pattern 4 is one of the big issues, because as we started 3, in the end we have 3, 4 and 5. So we have a 3 tiers, more or less 3 tiers system, which is more or less true because we also have the second Gleason pattern. Nevertheless, Gleason 4 means that you have a tumor which is not perfectly well differentiated. And according to how much of this Gleason 4 and what type of Gleason 4, because you have very many different aspects, what type you have, you will be put into another group of treatment. Which means very often we say, well, Gleason 6, very small focus on the biopsy. These people can be treated with active surveillance. We have older patients. Older means, let's say, 75. They have, let's say, 10 biopsies negative, 1 biopsy with a Gleason score 3 plus 3, 2 millimeters, and the 12th biopsy is with a Gleason 3 plus 4, so 7, Gleason score 7, and there are 10% of Gleason 4. So probably these patients also can be in active surveillance, because if you have less than 6% of 4 or 10% according to the studies, you have exactly the same prognostic as having a 3+3. But if you have, for example, cribriform aspects, which still belong to the group 4, in these cases, you have a more aggressive disease. And in this case, you should not be put into active surveillance, probably. And you have some kind of tumors which are really 8, so this is 4+4, so this of course is not very good. These patients have to be treated differently than with active surveillance. You can have ductal carcinomas, which are rare and difficult to recognize, which are always Gleason pattern 4 too. So these patients are really should not be treated with active surveillance, because we know this aggressive. So 4, as long as it's under 10%, it's probably not a drama. Over 10%, you really should discuss other treatment options, and there are very many treatment options now in prostate cancer. So cribriform is a very hot topic in pathology at the very moment. Cribriform means that if you have a cribriform cancer, it means that you have lost your basal cells, so the tumor is invasive, and it's Gleason pattern 4, and it's an aggressive Gleason pattern 4, which means no active surveillance, of course, and probably some other kind of treatment. There have been voices saying, well, if you have these cribriform patterns, these people probably should be treated, should have a germline testing, because maybe they have BRCA mutations, and if you have BRCA mutations, you have different type of prostate cancer which can be treated in a different manner with different therapies. On the other hand, the problem is to report cribriform, and there have been made very many efforts from the pathology side to make sure that everybody says cribriform on the same thing. So now we have definitions about cribriform which are pretty good, and normally everybody should see the same with cribriform. In the older classifications, the small cribriform nests were still in Gleason pattern 3. In 2016, every cribriform was put into Gleason pattern 4. So intraductal means that you have a kind of tumor in the lumen of the ductae or an acini, but it's not invasive. So normally you shouldn't give any Gleason grade or score because it's not invasive. But very often you have beside, let's say 98% of the tumors you have beside an invasive tumor, and of course these tumors should be graded with the Gleason score like always. And there are two theories about these intraductal tumors. One say, well, there's an invasive tumor which pushes towards this ductae and acini, and then you have these intraductal features, but the invasive tumor is not very far away. And sometimes, probably 2% of the patients will just have this kind of intraductal without any invasive component. And these are very tricky cases because you do not really know what to do. So when we have this on a biopsy, which is really extremely rare, but I had recently a case like this. I had a very small intraductal component and no invasive tumor. Well, then you say, please do some more imaging, once again, MRI, and please do some more biopsies, and maybe then we will find an invasive component. This patient was rebiopsied, there was no invasive component, so I said, well, I think it's okay now, maybe follow up in 1 year or 2 years, but at the very moment there does not seem to be any invasive component. PNI is perineural invasion. In prostate, it's, I would say, not so important because very often you see this perineural invasion, especially on the prostatectomy. There have been very few studies saying that the tumor is really attracted by the nerve sheaths, and the nerve sheaths attract the tumor. So it's pretty obvious that you have this kind of aspects, but this has never been one of the major risk factors in the end. PNI is seen, I would say, in at least 80% of the prostatectomy. So it's really very frequent, and it's you know, you have a scale 1, 2, 3, 4 risk groups, and it's in the scale 3 risk group. So it's not very important in the way. By the way, if you have this kind of perineal invasion, you should never give a Gleason score around this, because they always look like 4, but it's probably not a 4. It's probably 3 or something else. So you have to be very cautious with this one. You know, I'm a specialist in uropathology, and I mean, everybody who is specialized in uropathology sees more or less the same thing as the other guy who does uropathology. The problem starts when people have to do everything, because of course you cannot be a super specialist in everything. I mean, if I would have to do some, I don't know, thyroid cancer tomorrow, I would be lousy, right? I mean, maybe I would recognize, but not even sure about this one. So, and we have made some studies showing that, which showed that the pathologists who are not used to do daily uropathology have a tendency to grade a little bit higher. So they give a little bit higher Gleason score in the reports than would do the uropathologists who are used to it. So if you are not sure about your own diagnosis, you know, of course you can send, and I have very many second opinions, not very many in prostate, but very many in other tumors. I mean, if you have the impression that it could be interesting for somebody to have a second opinion, why not? But I would say it's not that difficult, and globally people are very well, do very well. Really, most of the time I really agree with the second opinions people send to me. So Decipher and of course all these oncotype tests, and there's also Polaris, are very well established tests now. Some of them are playing with a kind of genetic signature, and depending on whether you send the biopsy or you have prostatectomy, they will tell you the risk of your biochemical recurrence, the risk of having a recurrence, the risk of having distant metastases, and probably also your survival. But you know, I mean, these tests cost a lot. They're not really reimbursed. They cost really a lot. They're not reimbursed most of the time, except probably, I don't know about the States, with the private social security systems. I don't have a clue about that one. But otherwise, it can be interesting, of course. But on the other hand, you know, it's always based on stats, on statistics. So of course it might be right, but on the other hand, I mean, every person is an individual person, and there are very many other tests which, in my opinion, are at least as interesting. We have worked and we have published genetic signature in 2018 in the Annals of Oncology, and this is now commercially available, which is called Prostate Diag, which works more or less also with a genetic signature. But you also have to be very careful what you're looking at in these signatures. So our signature, for example, is for low risk tumors, and we can predict pretty well whether a person has a low risk, even if he has a high Gleason score. Some people have high Gleason scores and you think it's a poorly differentiated tumor, but in the end he has a very low risk. So Oncotype and Decipher, of course, and Polaris, all these tests work a little bit in the same manner. So if you're interested in that, of course, it's interesting. In my opinion, what is much more interesting is, for example, if you have a family history of prostate cancer, or your mother has had breast cancer or ovarian cancer, we know very well that there are these kind of diseases now, then these patients should have a germline testing probably of the BRCA mutations or ATM mutations to make sure that they do not have this, or microsatellite instability. We know more and more about the genetic underpinnings and the molecular underpinnings now in these tumors, because they would, of course, then be offered a different treatment with the PARP inhibitors, for example, and this is something which works really very well, but only in this kind of patients. So you have to be sure that they have really this kind of genetic alterations, otherwise it's useless to give.